Hi, my name's Tony, and I'm here to talk about CPR, or cardiopulmonary resuscitation. I'm doing this because it's a course that I teach, and I've been teaching for a good 20 years plus. And after a relatively recent class, one of my students, his name was Ernie, he was working out at the gym some months later, and where he was working out, there was a guy who collapsed in cardiac arrest. And Ernie called me that same day to tell me how it went, how everything went just kind of like I described. And they were actually able to, with Ernie's help, a return of spontaneous circulation on this person. We call it ROS. I don't know what happened with the patient, but Ernie did his part by doing the most basic skill well and gave this guy the best chance of coming back to life that, well, anyone can give. So, after teaching this so many times, I thought, what are the things that I see go wrong in the field? Well, I've been a paramedic since 1995, and I've been working continuously in the civilian world as a fire medic, as an ambulance medic, as a flight medic, and in the military for almost 15 years as a military medic in the Navy and the Army. I've seen lots and lots of CPR done, hundreds of times, and I've done it myself dozens of times. There's some mistakes that come up over and over again, and even though on paper this looks like the simplest thing in the world to do, it's like every simple thing. There are degrees of skill and detail that make it either effective or dangerous. So I'm going to cover the things that I find out are most commonly missed and that are not really well covered in even the American Red Cross course or the American Heart Association course for CPR. And I'll be honest with you, the vast majority of CPR instructors I see teaching have no clue about this either. So let's get to it. First thing for reference points, we've got, I don't know, we call him Joe. I've circled his nipples just as a reference point because I don't know how well you'll see it on camera, and basically the lower part where his sternal notch is. So the first thing is essentially if you're going to do chest compressions, just basically plant them on that imaginary line. You can be slightly below or just at it. It really doesn't matter exactly because it's never a precise thing. People's hearts change position when they lie down. So just getting your hand on that imaginary line, and if you drew a sign of the cross, if you want to be religious about it, right where that intersection is, and you're going to be in a good spot. Mistake number one. When we're doing CPR, the focus is to look at our own hand. So as you can see, my line of sight goes straight up and down. What this means is instead of pumping up and down, straight up and down like a piston, compressing the heart, as you can see, I'll be looking at my hands and pushing more like a rocking motion. If I exaggerate it, you're going to see me rolling. So in a sense, I'm kind of squishing the heart sideways. How do I beat this? I want to go over and look at the person's far armpit. Now this mannequin, he's not the average size person. We'll say this is a skinny guy or an average girl, but this is what we have. So I put my hand in the center and I basically look over, and it's going to feel like I'm going over the side. My feet on this side are going to have to be outside of the arms. And as I look down, I compress. And as you can see, my arms are far more vertical. I do the best I can. If we have a big fat person or a huge person, you're going to do the best you can. But getting straight over to where your arms are vertical rather than at an angle, which is more common, will help a lot. When I do the compressions, for some God knows reason, I have no idea why, they keep teaching to keep your fingers off the chest. There's no good reason for this that I can divine ever. And the reason that I think it's harmful is because CPR is emphasizing more and more coming off the chest, just enough so you can like let a card swipe under your palm, because you want to allow for full recoil of the chest. When I squeeze down, I'm pushing blood outside of the heart. When I come up, it's creating essentially a negative pressure, which helps pull blood back in through the vena cava to the heart. So there's blood going into the heart, compress down, blood goes out of the heart. Come up, blood gets sucked back into the heart. this also works for breathing. As I push down, air gets pushed out. As I let up, air gets pulled in, just like normal respiration. So, how do I keep my hands from bouncing all over the place as I'm doing this? Is I keep my reference points. I have my hands right there, my heel of the hand, the intersection of that cross, and I just keep a couple of fingers touching. So as I go down, I push like this here. My fingers are just there to keep me from wandering all over the place. Don't want to take this to excess. One of the most recent cardiac arrest patients I went on, there were professional rescuers, people who were experienced at CPR, and they were taking turns. The normal thing in pre-hospital is to try to switch every 1 to 2 minutes, because I don't care how big or strong you are, the quality of your compressions goes to crap after a while. You just get tired. So the one guy was doing compressions like this here and rocking her side to side like she was a quarter log. And this made me cringe. Then the next guy took over and he was doing this here. I think I broke my mannequin. Like this. Big dude. After 15 minutes of this going on, back and forth, something ruptured inside and bleeding happened from the trachea, and I know because she was intubated and the blood was coming out of the tube. So there was internal damage done, and that was because instead of thinking of a pump where you're trying to push up and down, he was palm striking and beating the chest. Well, shoot, if I sit there and beat someone down, it'll be like DMOC, or that palm strike of death to the heart. CPR is traumatic to the chest. You will damage the ribs and cartilage between the ribs. You will break some ribs. You may even poke some holes in the liver and cause other microtrauma to the lungs. But these things almost never kill the person. And the better the CPR is, the more chance the person will regain spontaneous circulation earlier, because it's a fact that the longer you're doing chest compressions, the greater the chance of serious injury to the chest and the blood vessels in the chest. This is, again, and people that have been doing chest compressions many times for years, and on scene with professional providers, there's this no one wants to say anything because it's such a quote-unquote basic skill that it's almost insulting if you teach anyone this. And in regular schools, if instructors who are teaching this don't realize what's going on, they're not going to catch it. And your average Red Cross or AHA instructor, unless they work in the field, they may have done CPR on like a sheep carcass or something, and it's a completely different layout. So the first thing is, again, making your piston effective. So you want to push down, and that means leaning far over as you can so your arms are vertical. You'll feel almost off balance, but that's natural. Next thing is keep a reference point so your fingers are holding onto the chest so you're not bouncing all over the place. And lift the heel of your hand enough to think like you're swiping a credit card underneath it. I credit Dr. Dan Davis for this little word minder. And as far as the rate, just think of a heartbeat. You're going to be approximately in the right zone like this here. If you go too fast, you're going to be shallow and you're really going to actually cause more damage. If you go too slow, well, it's better than nothing. And the final point I would say is breathe. In new people, especially if you haven't done CPR, or if you haven't done it a lot, or even someone who's professional who sees someone, a loved one or a friend collapse, because it's like someone you know, it's going to stress you out. I've had this happen to me a couple of times, once in the Army, once a couple times in the civilian world, where people that I knew, they coded. And I'm stuck there, whoa, Mr. Paramedic with all these tools, but guess what I have to regress to? The most original thing, which is keeping them alive long enough until I can get a defibrillator and basically correct whatever underlying rhythm is failing. So with the chest compressions, I'm doing CPR. I'm emotional now because it's someone I know. I want to do well. I don't want to screw up. I'm trying to think, am I missing anything? And what you can take comfort in is if you're doing good compressions, you're centered, you're going up and down, you're going basically about halfway down. Just you'll feel the chest kind of stop. You don't have to force it. You're going to be doing the best you can. So while you're doing all this, don't hold your breath. If you hold your breath, because you're tense, you're going to get tired that much faster. Take a breath. Breathe. Notice how my arms are still, or I should say locked out. So you should feel this more in your butt, in your hips, and about this rate. And you can keep this up for quite a long time if you remember to breathe. A couple questions that have come to mind as I'm doing this, and you can write some in the comments, is mainly from people who've never done this. So say you're Joe Blow and you're doing CPR and it's a chick. Okay, she's got boobs, and when girls are upright, their boobs, if they're pendulous, they'll hang down. And you're like, where do I put my damn hands? You said between the nipple line, and now the nipple line's there. Well, guess what? When people lie down, those same boobs flop over to the side. You're going to be able to tell. They'll kind of squish to the side, and the nipples will be approximately the same line. And again, this little class here is not meant to take the place of a CPR course. I'm detailing the things that are messed up even by people who are CPR certified. So nipple line basically self-corrects. If you have the presence of mind, or you have someone else there, and you know that 911 has been activated and first responders are coming, you may want to consider cutting away the shirt, cutting the bra, if there's a bra, because when first responders get there, one of the first things they're going to want to do is put electrodes. And they may put one up front and one in the back, or they may put one here and one there. So any clothing is going to get in the way, and you'll have to cut that away. If you don't do it, who cares? Not a big deal. They've got shears. They've been doing it before, and that's it. You're still doing the most important part. What about mouth to mouth? When I first started CPR, when I was trained, I should say, when I was first trained in CPR in 1988, when I was still in the Marines, we were still doing 5 compressions in 1 breath. Oh my God, what a mess that was. 5 compressions, 1 breath. And then it went to 15 and 2, and then it went to 30 and 2. And now there's like this whole, well, what the hell? Some systems, they do 100 compressions in 2 breaths, and I've seen it work all ways. But one thing for sure, every time you stop compressions, whatever the reason, every time you stop compressions, everything, the heart, blood output, the blood flow to the brain, which is what the CPR is actually doing, okay? You can almost get no blood to the heart doing chest compressions, and that's because coronary circulation happens during diastole, which is kind of in that upstroke and is really hard to get any pressure. That's one of the reasons we give epinephrine in the field. You're really pumping blood to the brain because the brain is what dies within just a few minutes. Kidneys, right on its ass. Okay, so you're feeding the brain and the kidneys, and they're almost equidistant. The kidneys are right about here, the brain's right about here. So every compression you're doing is sending blood to the brain. You're not saving the heart, you're saving the brain. So what about the breathing part? Well, think about, if you took a CPR course, what the care is for an obstructed airway. Someone who sucks down a piece of food or whatever and they're down. How do you treat that? Chest compressions. Why? Because every time you compress the chest, you're pushing air out, residual air from the thoracic cavity, out the mouth. So good solid chest compressions will push air out of the mouth. Well, if you pushed air out during the downstroke, guess what gets sucked back in during the upstroke? Air. Now, is that as much air as they would get breathing normally? No. However, instead of breathing 12 to 15 or 16 times a minute like an average person breathes, they're breathing effectively 80 times, maybe 90 times a minute with those compressions. The second thing is, as they're sucking in the air those 80, 90 times a minute, they don't need as much air because you're having a person who's essentially, clinically dead. That means their heart's not beating, they're not doing anything except just being dead, okay? So how much oxygen do they need? How much blood flow do they actually need? Estimates are that CPR provides about 30% of the blood flow of a spontaneously beating heart, and that's if the CPR is being done well. Capnography shows that we can get very good CO2 returns, which shows a kind of indirect measure of the body's metabolism. So really they do okay. When first responders get there, they're going to throw a mask on with some extra oxygen. They may do some artificial respirations, but that's it's hard to say just how much that really helps. The breathing and the circulation come through those effective chest compressions. There's a video, and if I can find it, I'll post it, of a man on whom chest compressions are being done. It's a young man. Don't know the background story, it was in another country, but when we all saw it, we thought it was fake because someone was doing chest compressions on this guy, and after doing chest compressions a bit, the guy would like wake up, and he's usually the first thing they do is try to swat your hands away because it hurts. And as soon as a guy like who's doing chest compressions like horrified and stops doing the chest compressions, the dude conks out again. So when this video first came out, it was like, this is a load of shit. And I sent it to, again, Dr. Davis, and he said actually he had a case like that where he worked in San Diego, where they had a woman where they were doing chest compressions on, and the chest compressions were done so well that she would wake up and come to, and they would stop compressions and she would immediately go out again. So this was telling him that whatever was going on with the heart, it was so ineffective, so weak, it could not keep enough blood flow to keep them conscious. So the chest compressions were really, really working. In the video case, I have no idea what the outcome was. In the other story, as told to me by the doctor, it was kind of heartbreaking because I don't know the details of the story in terms of the physiology or pathology that was going on. However, they were able to do compressions on her long enough to get some of her loved ones or loved one there to say goodbye. And the chest compressions, even if they didn't bring her like life back in the long term, it brought her back to life long enough to matter to those that she wanted to say goodbye to. So I hope this was informative, just pulling everything out of my ass in terms of what I've thought of to pass on that I know would make first responders better chest compressions. And if you are not a first responder, it'll make you as good as or better than a first responder when it comes to CPR when it's your time to do it.